Alpha-1 antitrypsin deficiency is a genetic disease. It's inherited as an autosomal codominant condition, is that in individuals with COPD, there is a failure to test for alpha-1 antitrypsin deficiency as a predisposition to their chronic obstructive pulmonary disease. Textbook descriptions of alpha-1 are individuals who develop COPD at a young age, having never smoked, and with lower lobe predominant emphysema.
Welcome to part 1 of our conversation with respiratory physician Dr. James Stoller on Alpha-1 antitrypsin deficiency. Let's dive in. Okay, so we're going to move on to our long-form questions now. So let's dive in. So starting with the basics. Now, as a paediatrician myself, Alpha-1 isn't something that I see commonly, but I do remember back to my medical school days and reading the page in Kumar and Clark's Clinical Medicine about Alpha-1 antitrypsin deficiency. So for those like myself who don't come across it often or who are hearing about it for the first time, what is Alpha-1 antitrypsin deficiency and how does it affect the lungs?
Great question. Alpha-1 antitrypsin deficiency is a genetic disease. It's inherited as an autosomal codominant condition. And in the severe deficient state, alpha-1 antitrypsin deficiency results in inadequate alpha-1 antitrypsin in the bloodstream and therefore inadequate alpha-1 antitrypsin in the lung. Alpha-1 antitrypsin as a protein is an antiprotease. It binds and neutralizes one of the proteolytic enzymes that can be released by neutrophils in the lung called neutrophil elastase. Neutrophil elastase in the lung, while potentially neutralizing bacteria, can also break down alveolar walls. And so unchecked proteolytic damage in the lung by neutrophil elastase can cause emphysema. Alpha-1 antitrypsin neutralizes neutrophil elastase, and in so doing, protects the lung against proteolytic damage, exacerbated in smokers, of course, that can result in emphysema. Through a different mechanism, the so-called toxic gain of function, alpha-1 antitrypsin is a hepatic inclusion disease. And in some of the genotypes for alpha-1, the alpha-1 protein is not secreted from the hepatocyte, it accumulates within the hepatocyte, and that accumulation can trigger fibrosis and cirrhosis. So the pathogenesis is different in the lung, where there's too little alpha-1, than in the liver, where there's too much alpha-1.
Thank you. That's a really comprehensive explanation and it's very clear. And you've really highlighted why it is so important that we make the diagnosis of Alpha-1. And that brings me to my next question, which is why is this condition often underdiagnosed or misdiagnosed? And what is it that makes it so hard to spot?
That's a great question. Really, there are two dimensions of under-recognition of Alpha-1. First of all, the most common clinical manifestation is, of course, chronic obstructive pulmonary disease. And chronic obstructive pulmonary disease is under-recognized itself, at least in the United States, where there are estimated 25 million Americans with COPD. Only half of them have been diagnosed as having COPD. The second reason for under-recognition of Alpha-1 is that in individuals with COPD, there is a failure to test for alpha-1 antitrypsin deficiency as a predisposition to their chronic obstructive pulmonary disease. And so every patient, guidelines suggest that every patient with COPD, with fixed airflow obstruction on pulmonary function tests, should be tested with a serum level and a genotype, simple blood tests, for alpha-1 antitrypsin deficiency.
And I think that's something we're going to come on to in a bit more detail later on in our discussion. But as you mentioned, it's a genetic condition and there's often a lack of family history. Can you talk a bit about the genetic complexities and variability of expression in Alpha-1?
Yes, it is an autosomal codominant condition, meaning that each parent contributes an allele to the severely deficient progeny, that the inheritance of two severe deficient alleles causes a specific set of genotypes that is associated with severe deficiency of alpha-1. The parents, the heterozygous state, a normal gene and one abnormal gene, may be free of clinical expression. Individuals, for example, who are MZ, M being the normal wild type allele, Z being the most common severe deficient allele, individuals who are MZ, who don't smoke, may be completely free of disease and so may go underrecognized. And so two parents that are heterozygotes have a 1 in 4 chance per child of having a ZZ homozygote who is severely deficient. In that instance, the parents may go underrecognized, and the child, on reaching adulthood, with regard to lung disease, or even in childhood with regard to liver disease, may present with alpha-1 antitrypsin deficiency related symptoms.
And are there any specific risk factors or clinical signs that should prompt a clinician to consider alpha-1?
Well, there are. I say this with some trepidation. The classic textbook descriptions of alpha-1 are individuals who develop COPD at a young age, having never smoked, and with lower lobe predominant emphysema. If one sees such a patient, that should certainly prompt suspicion of alpha-1. Having said that, many patients present with alpha-1 antitrypsin deficiency without the classic presentations. For example, a third of individuals may have upper lobe emphysema. It is not confined to young individuals, and so that older individuals who smoke are certainly at risk of developing emphysema related to alpha-1 antitrypsin deficiency. And so guidelines, again, suggest that every patient with chronic obstructive pulmonary disease should be tested for alpha-1 antitrypsin deficiency, as should first-degree relatives of a severe deficient individual, as should individuals who have chronic liver disease that is otherwise unexplained.
That wraps up part 1. Thanks for listening. Be sure to join us for part 2, where we continue our conversation with Dr. James Stoller.